Hello, thank you for your talk earlier. That was really excellent.
Even though you corrected my gene nomenclature afterwards.
Well, small point, small point. There was a lot you could have talked about, and you have talked previously about biomolecular pathways, and you mentioned this, kind of alluded to it several times. I think one comment was there's multiple rare causes of diseases with common pathways. So we have all these different genetic loci, but they have all the same pathway or similar. I wondered if you could just update us a little bit on how your understanding and your research group understanding of the molecular pathways is progressing.
Okay, that's a long question, but I'll do a very brief answer. So basically, the disability in CMT is due to damage to the axon, not to the myelin sheet. So even in CMT type 1, where the problem starts in the myelin sheet, the problem you get is due to secondary damage to the axon. And proof of that is there is a gene known, a gene which has been found in a family who are normal. Now you might ask, how did a normal family end up having the test done? And it was an accident, not in England, elsewhere. Someone had a neurophysiology test that showed slow conduction. Then they found the family had autosomal dominant slow conduction, and on a biopsy had thin myelin, but completely normal axons, and that family never got a problem. So we know the myelin in itself won't cause a problem in CMT, it's the axon. So what do axons do? Well, for our nerves to work, they need a huge amount of energy. So if you think about the longest cell in the body is your leg nerve, your nerve from your back to your big toe. It varies depending how tall you are. And in large epidemiological studies in the world, if you forget about CMT and talk about neuropathy is commoner in tall people. So it's slightly commoner in tall people. And that's probably because they have longer nerves. So you have we know it's to do with your nerves being long, and we know if I have something at the moment that gets transported down my nerve from my back to my toe, some of those molecules take a year to go the whole way down. So there's fast transporters and there's slow transporters. So we think this thing called axonal transport, the transport of nutrients down and of, if you want to call it the side products up again, is what's really important. And most of the pathways we've discovered are involved in that. And if I had to say what has been the biggest discovery in the last 3 or 4 years is how important the mitochondria are. So the mitochondria are energy packets in each cell in our body. And there are different kinds of genes for those, but there are some which are determined by genes that are in the nucleus. And they are turning out, so the last 4 or 5 genes that have been found in CMT are to do with the mitochondria, to do with energy production, bringing things up and down. And one of the things looking forward to therapies is, as well as thinking of specific genes, I always use the analogy, if we end up treating CMT, you can look at specific gene therapies, you can look at, say, PMP22, reducing the amount. But when we treat diabetes, or when we treat high blood pressure, we don't worry about the cause. We get the sugar down and we get the blood pressure down. So we'd always should keep in mind, can we find why there is a problem with axonal transport and find a pill for it? Of course, we'd then be treating diabetes and everything else, but it's another way of looking at things. So this idea of common pathways is very important. And the other group of genes we have discovered in distal hereditary motor neuropathy recently, some of which are impressed but haven't been published yet, are again to do with different transport but not mitochondrial. It's again running up and down the neurofilaments and the microtubules. So I think axonal transport has turned out not unexpectedly, because that would explain why the legs are involved worse than the hands in most people, not everyone. The other thing which I think we're beginning to learn, which is difficult, is I would have thought that muscles were muscles. Doesn't matter if they're in your hand, doesn't matter if they're in your leg, you've got muscles. But from doing MRI studies, it's been particularly in muscle disease, perhaps a little more than nerves, because nerves, the nerve doesn't work, the muscle won't. But in muscles, the problem is in the muscle. And it is absolutely astounding, if you do an MRI scan of a calf or a thigh, that some muscles are totally normal and other muscles have 1% function. Now, why is that? And what we're beginning to learn is each muscle is different. And that's probably why some people with CMT get hands first and not legs, is that individually, why are all muscles are probably not all the same. So your muscle for your thumb probably needs a lot of a different makeup than the muscles for the top of your leg. They do different things. And that's why, for instance, your eye muscles, the 6 muscles that control eye movements, are really full of mitochondria, because they're, you move your eyes the whole time. And they have to move exactly together or you get double vision. So they're the biggest amount of mitochondria in the body are in your eye muscles. So the makeup of individual muscles is different. which means different forms of CMT, even if the nerve to them is the same, may actually have a different end result depending on the makeup of the muscle. This is something we had not appreciated at all a few years ago, and we're only beginning to see this now. But I suppose thinking about it, it makes sense. So if you think about athletes, why have you these phenomenal athletes? And then you have other athletes that are good at long running, short running. It is to do with their muscles. And in East Germany, when there was still East Germany, before it was all Germany, they used to, premier athletes would get muscle biopsies at age 12 and 13 to work out whether they would be trained to be a long distance or short distance runner, because they'd work out their fibre type. So maybe it isn't that surprising that different muscles are different, and probably different in different people. So they're really where we're at in terms of understanding the pathogenesis. And what we've been able to do more recently with the individual nerves is two things. We can now look at the mitochondria moving in a nerve. We can actually do it under a microscope. We have a way of doing it. And the other thing we can do research-wise, which is called it's quite a big word. It's induced pluripotential stem cells. And what that means is, so when a sperm and an egg fuse, they form 4 cells, then they form 8 cells, then they form 12 cells. But eventually, some of those cells will become nervous tissue, some of those cells will become your stomach, some of those cells will become bone. So that's why we call them pluripotential, is when the cells could do anything before they become differentiated. So what we can now do is we can take biopsy of skin, and it's skin. And we can de-differentiate that down to, we can make it into a pluripotential cell, and then we can grow it up into a motor nerve. So we've been able to do that in the last few years. Now, we can't grow it up enough to give you a transplant of a nerve, but it means in an individual patient with an individual mutation, we can look at their nerve by having grown it from their skin to find out what's wrong with it. And that's really changed the way we do research. Of course, in the future, it'd be nice to think we could grow nerves and give them back, but that's a little bit further down the line. But 200 years ago, people thought if people flew, they were mad if they thought anyone would be flying one day, so you never know.